I know you probably have another class at 8 o'clock. So class rep, are you? How's your?
We don't actually.
Oh, you do not. Excellent.
Yes.
So far, how's your experience in anatomic pathology within and fourth year in general?
It has been good. We have been going to the morgue and the museum. So it has been interesting. Learning a lot of new content.
Mm-hmm.
Yes.
That sounds good. Of course, we always expect distinctions and a very healthy pass rate, similar to what you saw in your third year class. So just continue with that spirit.
Yes.
Great. So may I start now, or do other people still joining?
Yes. Can we allow just a few minutes? Like 35, 3 more minutes to allow students to. Okay.
Right.
Yeah.
Great. As you join, one of the things I'd like you to remind your classmates, class representative. I know in the logbook description I had mentioned that there should be photographs, but for you, I don't expect you to submit photographs of gross pathology that you see at the autopsy room. Photographs are a bit sensitive in forensics, and what I want from you is just good diagrams. You see the diagram charts that shows where the injuries are, or showing whatever pathology. Maybe that is a good substitute for actual gross photography, and you can leave the gross photography itself to the pathologists and the pathology registrars. I saw a few of you taking photographs with your own personal phones, and I would not recommend that. It's a dicey area.
Okay.
Great. But otherwise, I just expect 3 detailed reports, and I think you've seen a few sample reports that I posted in the Google Classroom, the one that you had in third year and I transitioned to fourth year. So there are certain detailed reports. Yeah. So if you could present reports in that format with a lot of detail. And I'm also looking forward to opinions, and specifically opinion is answering the main question of how similar mortalities can be prevented. Various a contextual interpretation of the cases that you have seen. Best done individually. I know some of you want to do that as a group. I prefer individual thinking, at least in that section.
Okay.
Right.
Doc, I think it's 7:35, so we can begin.
Thank you very much, class representative. Let me begin then. So, so the talk today is on gastrointestinal birth defects, and I'm glad that you have completed at least your first chapter on cardiovascular pathology, and now you've moved to the next one. You realize in this year we tend to move a bit fast, and I hope that your personal reading is also on schedule as you read through the topic in your reference textbook, the pathologic basis of disease. So, birth defects, of course, if you look at the contextual description, you remember I showed you this slide last year when we were discussing the pathology of birth defects and pediatric pathology in general. And you realize that if you put together diseases that we see in newborns, you see perinatal conditions ranking here at 9% of total causes of death. And if we move on to this other side, we are seeing perinatal disease again causing 10% of overall disability. And again, we see 1.7% of permanent disability are due to congenital anomalies. And it just shows how serious these diseases are. And unfortunately, as you've seen from the autopsy, in spite of the high mortality rate related to these conditions, we perform very few autopsies to identify the underlying causes, and of course to define the pathology. Just to remind you what we discussed last year, birth defects are either isolated defects affecting perhaps a single body region, and these isolated ones tend to have a multifactorial etiological or multifactorial etiology. And you remember from last year when we used the term multifactorial, we mean that there is an interplay between genetics and the environment, and sometimes the environment may supersede. When we describe multiple defects, then there is usually a chromosomal a disease process, one of those big chromosomal pathology, either aneuploidies or translocations and so on. And these can be sporadic, but some of them are acquired through Mendelian inheritance. Now, I'll move off and now look at the structural components in terms of the nomenclature, or just basically the nomenclature of birth defects. So a birth defect, I know we use the term congenital malformation to mean all birth defects, but this diagram reminds you that a malformation refers to a very specific type of birth defect where the abnormality is present from conception onwards. And this pathology is intrinsic with the failure of an embryonic proliferation and or differentiation, eventually resulting to an abnormal structure. So if it starts from the word go, from conception, and it's intrinsic because of that. The second group are disruptions. When you use the term disruptions, what do we mean? So there's an initially normal developmental process where at some point there is interference with embryonic development due to an extrinsic agent, and that leads to destruction or removal of a structure. The third group are the dysplasias, where there is an intrinsic defect that leads to abnormalities in the organization of cells into tissues, and that eventually leads to abnormal structure. And these three are described as mainly intrinsic. This is intrinsic. This is a combination of intrinsic and extrinsic disease processes. But now the last one, this is a deformation. And this is where there is an extrinsic force, or there is a mechanical force that leads to distortion and destruction, usually distortion of a structure. And additional, so those are the proper definitions. Whenever you're using the term, those terms, then you know what they mean. Additional terms that we use, such as anomaly. Anomaly just means any deviation from expected or average type of structure. I've mentioned what malformation and dysplasias are. I've mentioned what disruptions, deformations are. You remember what a sequence is? So you have multiple anomalies derived from a single known or presumed anomaly with a mechanical factor. For example, the Porter sequence, where there is a renal agenesis, which will result in oligohydramnios because there is no urine production into the amniotic fluid, resulting in pulmonary hypoplasias because there is lack of movement of the chest. The other is say prune belly, where there is absence of abdominal muscles, where there is attenuation of smooth muscle, leading to attenuation of smooth muscle without differentiation into circular and longitudinal morphological forms. So, of course, you can imagine how that will affect motility. We discussed associations as non-random idiopathic occurrence of multiple anomalies, usually occurring during blastogenesis. And a lot of these do not have genetic components. Their causes are usually unclear. The syndrome is anomalies that are pathogenetically related and have a specific single cause, right? Such as the Beck-Widman syndrome. And then, of course, we always use quantitative terminology: hypertrophy, atrophy, aplasia, agenesis. Again, just to remind you about the causes, most of them can be due to defects of pre-genesis. And remember, those ones were genetic abnormalities in sperm and ova, leading to an abnormal conceptus from the word go. Disorders of blastogenesis, where there is mainly the action of teratogens or other disruptive agents. Anomalies of organogenesis, certain teratogens work at this point, and of course, phenogenesis, which is from 8 weeks till birth, where you expect this fetus to simply grow and develop, and you tend to see that. The pediatric surgeons will present you with this diagram just to show you the proportion of cases of gastrointestinal birth defects. You can see that the vast majority tend to be anal defects, followed by vertebral defects, followed by bone defects, which I'm not going to talk about today. And of course, the tractoesophageal fistula. And a lot of them tend to be part of the Vata association. Right, so we look at it. I'll not talk much about the mouth, but we look at, and I won't also talk much about the liver. So if you look at the head and neck, there can be jaw abnormalities such as micrognathia in Robin sequence or Down syndrome, and then isolated lip anomalies such as clefting, microstomia, pits, labial frenulae, and synecdoche. Clefts are, of course, the most famous. You've listened to discussions on the cleft palate and lip and various surgical teams that do outreach for this specific pathology. And it can either involve the lip only or also involve the palate. And in some situations, it's isolated just within the palate. And in the most extreme situation, it's bilateral. If you look at the tongue, there are various birth defects, fairly rare, I think, because most of them may be incompatible with life anyway. And the ones that tend to occur, the macroglossias related to particularly Beck-Widman syndrome, can see it in Downs and various other syndromes. And the Beckwith-Widman, we've of course mentioned it quite a bit because the pediatricians, I think this is one of their favorite MCQs. So next year they will talk about Beckwith-Widman and you will properly mention. But the main pathology related to it, large organs, particularly pancreas, kidney, liver, and of course the tongue. And with a tongue like this, there's definitely difficulty in swallowing. So there'll definitely be polyhydramnios. And there's usually hyperinsulinemia as well. In the oral cavity, there can be cysts or pseudocysts. I'll discuss cysts again later on. Congenital tumors like choristomas and epulis, the nasopharyngeal um, remnants such as cystic lesions of the brachial pouch, and of course pharyngeal lesions, again, lesions of the pharyngeal pouch. So oral and pharyngeal defects are usually they're fairly common, and many of them can be treated with surgery. The the pediatric surgeons will tell you next year in their classes that prompt diagnosis and quick or early referral is what you really need to do in most of these disease processes. Now, the esophagus can either be a short esophagus or atretic with fistulae, and I'll talk about cysts and duplications later, and of course, in some situations, congenital stenosis. And that's why you saw in the autopsy that we do, one of the first things I do was to dissect from a posterior end the entire length of the esophagus, as I'm carefully looking for atretic foci or tracheoesophageal fistula in that pediatric case that we did together. So esophageal atresias and fistulas are fairly common in 1 to 3,000 live births. Just to give you the context, there are 70,000 live births at Kenyatta National Hospital every year. So how many will you see? Quite a number you can see already. And this will present as polyhydramnios and coexistent duplications and foregut malformations may be seen. Right. So what are the types? This order presents the type based on on which one is most common. So green here represents esophagus, blue is a trachea. So type C is a distal esophageal fistula with a proximal esophageal atresia. Type A has both the proximal and distal esophageal atresia with a segment which looks missing really. Type D is proximal and distal atresia with bilateral with fistula. Type B is proximal fistula with distal atresia. And in the H type, there is a fistula between the esophagus and the esophagus and the trachea. And just for diagrammatic representation, this is exactly what this means. So here I have organized them based on the types from A to A, B, C, D, and E. And as I mentioned earlier, you can see type C is the most common, where there's a distal fistula and proximal atresia. Right. So, of course, this is esophageal lesions are treatable. There is, if you notice this child cannot swallow, or if they swallow, there's aspiration, then indeed you need to consider that and refer appropriately, or if you can investigate, do what you need to do so that they can be treated through surgery. There can be other anomalies such as tracheal anomalies. Maybe we'll discuss this one in the next topic on respiratory pathology and tracheal agenesis. Remember, the trachea and the esophagus are both derivatives of the foregut, so they can have these abnormalities. Now, I mentioned earlier that I'll talk about cysts. So, of course, a cyst is a fluid-filled epithelial-lined structure. And cysts that are associated with gastrointestinal birth defects are usually duplication cysts, meaning that, for example, in this area, there was development of esophageal mucosa-lined structures right here. And this being a duplication may not necessarily communicate with the esophagus itself. And if you look at the morphology of the cyst, it will be lined by the same epithelium that we see on the esophagus. And that's also what happens in the gastric sites, duodenal or other intestinal sites. And that is why we call them the duplication cysts. And majority are jejunal-ileal. This is so common, right? That some of the surgeons usually say that God pretty much may have been a surgeon, so has been creating a lot of work for them. If there's a cyst, then it will cause obstruction. It will be up to them to correct it. Right. So what are these cysts and duplications? You'll come across various nomenclature in your reading. For example, you come across dorsal enteric remnants, posterior mediastinal cysts, dorsal enteric cyst, and like diverticular, but diverticular, what a diverticulum is, and of course, the implications. So duplications, as I mentioned earlier, these are cystic or tubular replicas of segments of gastrointestinal tract, which may communicate or sometimes may not communicate with the other remnants. And frequently share muscularis propria, maybe intramural, and there may be mucosa-associated epithelium. So an example here is a duplication cyst here of the esophagus, and you can see it has parts of the esophageal wall forming the cyst. And because many of them may not communicate, and they have the epithelial lining that will produce something, usually mucus, then a lot of this will be mucus-filled cysts. Now, a different kind of cyst is a neurenteric remnant or neurenteric cyst, which are diverticular, fistulas, and cysts, including fibrous cords that tend to originate from the dorsal midline of the gastrointestinal tract, extending in a cranial direction, and they're attached to the vertebral column and spinal cord, usually splitting the vertebra of the vertebra, right? The specific vertebra at that site. And most of these walls are composed and serosa. Sometimes ectopic glial tissue may be found. We may also see ectopic leptomeningeal tissue. So here's an example where there's a duplication cyst here that may communicate with the gastrointestinal system, and then may also communicate with the spinal canal. And this may be connected either by a fibrous band, that would be a lucky patient, or unfortunately in some circumstances by a fistula. And a chemical type of leptomeningitis involving the spinal cord in the newborn age in this circumstance. Right. So they have their own classification. There's a type 1, type 2, type 3, and type 4. About my connection, sorry. So definitely based on severity. Oh, how do we move on next? So what are complications of these abnormalities? Of course, is obstruction, perforation, abnormal function, and in some circumstances, malignancy. Right, let's move on to the stomach. In the stomach, there can be a gastria. The most common one, of course, is the infantile hypertrophic pyloric stenosis. And of course, there can be duplication cysts, as I've mentioned. And in some circumstances, there's gastric perforation of the newborn. The most common, of course, being the congenital hypertrophic pyloric stenosis. And you can see how common it is, 1 to 8 per thousand live births. And as I mentioned, for context, KNH has 70,000 live births. I mean, births yearly, in a year. Pumani Hospital has about 50,000, sometimes up to 100,000. So you can imagine the numbers that you're likely to come across. Now, the next thing of course, I'm not going to discuss each of this in detail. The next thing I'll talk about are intestinal birth defects. And to describe this, I need to remind you about certain developmental stages of the gastrointestinal tract, especially the midgut, where in early embryonic life, this is connected to the yolk sac and it terminates at the cloacal membrane. And then as the developmental processes progress, there are two processes. One is elongation, and then the second one is rotation. So whenever there's elongation of the midgut, there can, and this is physiological, there will be an umbilical hernia. And once there is a hernia, then there is rotation around the mesenteric axis, usually around the mesenteric artery. And do you remember the rotation sequence? The initial rotation was clockwise, 180 degrees, and then 270 degrees anti-clockwise. Class representative, do you remember that?
Yes, I do, actually.
Excellent.
Yes.
So because of that, the birth defects of the small intestine would involve hernias or abdominal wall defects, atresia, stenosis, malrotation, duplication, diverticular, including the Meckel's type, and heterotopias. So let me start with the abdominal wall defect. Again, 1 in 5,000, 1 in 20,000. And what you see is there are two kinds that I'm going to describe. One of them is what we call an omphalocele, where there is herniation of usually the jejunum and ileum into the proximal segment of the umbilical cord, really. And it forms an omphalocele covered by this membrane here. The good thing is that these ones, if you diagnose it and you have a pediatric surgeon, it's fairly easy to repair. The second more severe disease is gastroschisis, where there is a small defect on the right of the umbilical cord insertion, where there is evisceration of the intestines. And unlike the omphalocele, these intestines are not covered by a protective membrane. And if not properly treated, as you can see, this one, it is already swollen and red. So you can see it immediately gets inflamed. And because of this, there can be a hemorrhagic infarction. So because of this, it needs to be treated really fast. So the differences between the two is that in an omphalocele, there is a sac that sort of protects tissues from the elements, and this one does not have it. But the good thing is that they can be treated quite easily. Well, I'm not going to talk about bladder birth defects, but just to remind you that whenever we are discussing abdominal wall lesions, you also need to consider what is going on a bit lower down. Atresias and stenosis, most of them are intestinal, 50% duodenal, and one of them is the so-called annular pancreas, where there is development of a pancreatic, sort of like a ring around the duodenum. And then there are the various atresias from type 1, type 2, type 3A, type 3B, And type 3B, you can see the distal component is rotated along the, it is rotated somewhat and looks like what is described as an apple peel syndrome. And then there's a type 4 where there is proximal segmental atresias. And of course, that's it. I do mention this because we have a pot, we have a specimen of this within the museum. And of course, when we see this, they're usually quite dramatic. The surgeons do excise quite a huge segment here. Now, the next thing are diverticulum. So what's a diverticulum? So diverticulum is simply an outpouching of mucosa and wall. So the entire wall and mucosa, there's an outpouching. And sometimes this can have a blind end, can be obstructed. One of the diverticula that the surgeons work on a lot is the Meckel's diverticulum, and you can see its morphology. And based on the degree of rotation of volvulus around the diverticulum, then it is classified into A, B, C, D, E, and F. And this is based on severity of the disease process itself. And here's an example of a Merkel's diverticulum. Right. Then the next are abnormalities related to malrotation. As I mentioned, at 6 weeks, there's a physiological umbilical hernia, and then there's elongation. At 9 weeks, there's the initial rotation, which is 180 degrees clockwise. And at 11 weeks, there's a rotation again on the opposite direction, which will be 100 and what is the angle? 270 degrees in the anti-clockwise dimension after, after the reversal of the hernia. So this rotation leads the appendix to be located within the which left iliolumbar? It's usually left or right. No, it should be on the right. So that is where you see when we're looking at the appendix, the position of the appendix does tell us exactly whether there is presence of malrotation in this individual. So, of course, again, just to remind you, we are looking at the rotation. You can see it's on the x-axis and the angles I have mentioned. And this one you're familiar with from your studies of embryology. And if there is malrotation, then there are various abnormalities that will occur, and we'll identify them based on the position of the appendix. For example, when there's complete absence of rotation, then we find the appendix on the, all right. Class rep, do remind me, is the appendix usually on the left or on the right? In the usual normal situation?
I'm not sure. I think on the right.
The usual. Anyway, your colleagues can comment.
Yes.
But we do expect it on the left, of course. And sometimes if you find it on the right side, then you find that then there is definitely an abnormality of malrotation. And here are the various sites. So if you have this situation, the problem with malrotation is based on the vascular supply. So, and the absence of proper spatial distribution of the loops of gastrointestinal tract within the abdomen. And eventually this leads to increased tortuosity. And with this tortuosity, you can see that motility will be affected. And of course, the vascular supply is also affected. And that is what will identify the disorders of malrotation. So what is the main consequence of that? The main consequence is a midgut volvulus, where because of the lack of the rotation, first of all, there will be fibrous bands attached to the cecum. And at this point, there can be a rotation or volvulus that occurs in the anti-clockwise direction. And this will definitely lead to ischemia of the intestinal loops that are involved here. So just look at it. I can see there are some mentions in the chat, and I can see, oh, thank you very much for correcting me about the site of the appendix, everyone from Brian, from Joshua all the way to Stanley. Right, where are we going next? Now, the next one are abnormalities of motility, and the most important one is the Hirschsprung's disease, where there is failure of the migration of neural crest-derived plexi, and in the absence, there is an aganglionic megacolon, which is obstructive. So, what are the common findings of colonic aganglionosis? Can be a narrow segment. You can have a necrotizing enterocolitis and various other features. The last group of birth defects that I'll talk about are the anorectal malformations, and you can see how common they are. One in 2,500 live births, and you can see their distribution. So these abnormalities are different in females compared to males, but the differences are subtle. If you look at the normal situation, you expect the rectum and anus to be within the external sphincter within the anal valve itself. The first abnormality is atresia, where there is a missing anal canal. Sometimes it is separated by a membrane, but of course, sometimes it needs a little bit more surgery. The next one is a fistula, which is anterior to the anal valve. So instead of finding it in the right place, you find it within the perineum in the male, but in the female, you will find it attached to the vulva, and it becomes a rectovaginal fistula. I'm trying to get something here. What has happened? Okay. Oh, have I mentioned this? All right, sorry about this description. So in the female is that there is, again, a similar morphology where the anus is found within the perineum, just posterior to the vulva. The third type is now the fistula, where usually this is vulva, not vagina, but sometimes mainly this is vulva. So whenever we see a rectovalval fistula in this circumstance in the female, then we do see it. But in the male, it's a lot more severe because you will expect a fistula with the urethra. And in the fourth one, there is a single opening where you have a cloaca, where all three openings are on one side, while the males, of course, will have it on the upper part of the urethra. Great. So what I'm not going to talk about the enzyme pathologies. I'm not going to touch on the liver today. I expect you to maybe read up on it in Robbins, and various aspects of neonatal disease. Intersusception is particularly common, cystic fibrosis, and so on. So I'll conclude by saying that these are fairly common. If you look at the ratios, quite common, fairly good prognosis when diagnosed early. And whenever you see them, always look for other anomalies, either as part of the vector, L associations, and so on. Right, so I'll stop here. Thank you very much for your time. I'll just look through the chat to see if there's any question. Brian is asking about the immediate cause of death in type C. Are you talking about tracheoesophageal fistula? So those ones I will let you work out. But you realize if there is a fistula with particularly a tracheoesophageal fistula, if there is a proximal or distal fistula, then expect aspiration to the lung and aspiration pneumonias, which are usually quite severe. And these newborns are also unable to swallow, so expect severe nutritional anomalies. And in the short term, do expect electrolyte abnormalities because of dehydration and, of course, volume depletion. Any other questions? Sharon is asking about that. Well, I need you to know basically how to classify them. So the basic classification, as you can see, from type A all the way to the H type. And you should sort of know which one is most common, which one is the least common. And I know if you have that kind of knowledge, you will definitely save lives. Okay, I think we can now stop here. Thank you very much, class rep. I know you do have other classes to go to this morning. So let me wish you a very good day. Thank you
Thank
very
you,
much.
Doctor. Also, I wish you a good day ahead. I think there's one last question. How soon are the
right.
surgeries done after birth?
Well, of course, that'll leave the pediatric surgeons to discuss with you.
Yes.
But the sooner they're done, the better for many of them, particularly the major anomalies. For example, if there's no what if there's a tracheoesophageal fistula, there's need for something. It has to be done almost immediately. Or if a major abdominal wall defect, that has to be treated almost immediately, or else the newborn will definitely die. There may be a bit of delay in certain situations, such as extreme preterm births. There are some situations where you will read surgeries where there is surgery of the fetus while still in the womb, in the uterus. There are approaches for some defects in that age group. Others may be delayed, for example, the anorectal malformations, not anorectal, but motility disorders related to Hirschsprung's disease. This may be done at a later age as well. It depends on the circumstance. Now, Faith, what did you want? You'd like a document on preeclampsia? Or so what did, maybe you need a class representative,
Yes,
do
Doctor. I
send me a
reminded you.
message on that again. Oh, thank you. Sorry for that.
Okay, I'll reach out to you again.
Thank you very much. I'm glad you are interested in doing a lot of reading, reading beyond Robbins. So now that you've finished reading Robbins, it may be time for additional reading. Okay, thanks. So the next
Right,
adjourn
great.
till my next class, which will be the kidney now, right?
Yes.
In your fourth year course, I don't have too many classes. I just focus on just a few areas. So your next class with me will be on renal pathology. And by the time we meet again, you will be quite wizened by your exposure to pathology. You'll have read all those other chapters, gastrointestinal, renal, cardiovascular, which you've already read, respiratory system. I think you'll have also read about the CNS. So it will be towards the end of the course. And I'll come in and give a very detailed description of renal pathology. So I know some of you have already started reading. Please go ahead and continue. The other topic I'll talk about, but in a very brief, but will be quite brief, will be a topic on the lymph node, and I'll talk about benign lymph node lesions towards the end of the year. Right. So, so you continue reading. We will definitely interact during your rotations. I'll put in a lot more effort there.
Thank you, Doc.
Great. Thank you very much, Brian. I know you. Some of these diagnoses, they're just clinical diagnoses. You have to make them as a physician using the basic approaches of good history and examination. Some you'll just see. So once you have a good visual representation and you know about them, you should be able to diagnose them with minimal imaging. I know a lot of imaging might take you to, some of these are difficult to image and identify. But of course, I know, Brian, you're thinking of prenatal testing or antenatal testing. Maybe that is where imaging comes in, and you say that in the gastrointestinal tract, we can see from ultrasound, even before delivery, that there is there's an abdominal wall defect. And teams can prepare for that delivery. Right. So thank you very much. Another announcement, class representative, I'll remind you, Kenyatta National Hospital has asked me to talk about cause of death and basically how cause of death is assigned. They would like me to discuss this on their afternoon fora. So Tuesday afternoon from 2:00. I know you usually have other classes at that time. I will be discussing, I'll be providing more like a public CME to healthcare providers drawn throughout the country. Usually there are about 1,000 people logging in on cause of death, how causes of death are assigned. So I'll present a detailed description of that. So if you're interested, you could join.
Okay. Will I be able to get the link from you? Or
once I get it, I will forward it to you.
That is good.
Great.
That is okay. Thank you.
Thank you too. And do have a nice day. Bye-bye.